So we've discussed the basics of informed consent and special considerations. Let's apply it in the real world. Let's look at some cases. So here's a patient with visually significant ptosis. You examine her. There are no particular contraindications for her to become a surgical patient. And you talk with her about the potential benefits of a surgical procedure and the risks as well as the alternatives. And her response to you is, well, you're the doctor, whatever you think is best. Or the corollary statement that we all have gotten, if I were your, fill in the blank in this case, if I were your sister, what would you recommend? So what do we do in a situation like this? We might know what's best, but the patient knows better. And particularly in something elective like a ptosis procedure, our role is to give the patient as much information as they need to make that decision for themselves. So in this case, I would say, well, I might be the doctor, but you're the patient. And this is how this might benefit you. You don't have to have it done. You could talk about what happens if it gets worse and what the timing would be if they decided to delay surgery. So you just give them as many scenarios as they need to understand their condition and the chronicity of the condition and the urgency, if there is any, of medical treatment and intervention. And again, have them engaged. Let them ask questions if necessary, have them come back another time, maybe with a family member, another set of ears. Sometimes we'll give patients the confidence that they seek and they need to make a medical decision. But as we talked about before, again, recognize, except in urgent situations, that most of the time the patient should have the right to make the decision, and that patients will tend to do what we recommend. And we always have to recognize the power that we have that sometimes we don't recognize. Here's another situation. You have a child, he's 2 months old, he's got bilateral developmental cataracts. His dad had them too, had them removed when the father was in Ukraine many, many years ago. Now, your recommendation in this situation is that the patient undergo cataract extraction. But the father says, I don't want my son to go through surgery. He recalls his situation. When he was a child, he's got many bad memories of multiple hospital visits and doctor's visits and pain from surgery and eye drops. And he's managed throughout his adult life despite what he went through, but he's trying as best he can to save his son from the experience that he had. So in a situation like this, to whom is the physician's duty? We have a patient, but the patient is not the person giving the consent. Well, clearly in this case, our duty is to the patient, and the person giving the consent, we have to spend a little bit more time educating that person so that they will have all the information that they need to make an informed decision. So in a situation like this, we might consider having the father get some information, give them some information, refer them to websites so that he can get a little more educated and maybe understand how his son may not necessarily go through the same experience as he did. You might partner with another family who's gone through a similar experience with their child that the father would feel comfortable speaking with. You might ask, is mom around? Maybe ask mom to come in on a subsequent visit. Again, another pair of ears. Now, clearly, if you're in an academic setting, you have multiple tools at your disposal through social work and social services that could get involved if necessary. Not all of us have that type of outlet. In the end, we do have a legal avenue for having a court order for medical treatment. But for all sorts of reasons, that is not the ideal solution because we're going to need the parent to have buy-in with this decision because there's a lot of post-op care. So only as a last resort and in general, we can navigate these types of situations with more time and more information, more compassion, and more education. Not in my backyard. So we have a patient. They have visually significant cataracts and they're starting to have trouble with nighttime driving and reading and other visual tasks. And they're seen at a very large teaching hospital. It's a great case for an inexperienced resident. But the patient says, oh no, I watch these medical shows on television and thank you very much, but I would prefer not to have a resident cutting on me. So In teaching institutions, there's a medical hierarchy that we're all very familiar with, but patients often don't understand the many players, and they don't understand the difference between an attending and an intern and a fellow and a student. And some of our colleagues at Kresge did a study where they went around to different waiting rooms in the hospital and they handed out surveys to patients asking them about the different medical types of physicians and what they understood about it and what they knew. And what they found in general was that the more a patient understood about the medical hierarchy and how medical training occurs, the more comfortable they were with relatively inexperienced medical trainees being involved in their care. What they found was almost everybody wants to know the rank of the treating physician, whether it's an attending or a fellow. But fewer people understood those designations once they were aware of them. Now, a little bit over half of people said, I would not want to be a resident's first lumbar puncture. And over a third said, you know what, even if it's their 10th, I do not want to be a patient of a resident. So again, those who understood the medical system and the way we train people were much more likely to be comfortable with the involvement. But in the end, a patient has the right to know who is going to be treating them. And many patients, but not all, will consider it an honor when they are taking an active role in training a physician to be a senior doctor, but not everybody will. So we have a couple of options in a situation like this. We can say, Mrs. Smith, this is a teaching hospital and residents have to have a role in the care of the patients here. Now, we could send you to another doctor across town in a community hospital or a private office, and there you can have the undivided attention of the operating surgeon without the involvement of medical trainees or residents. Now, if everybody who came into a teaching hospital had that sentiment and had that request, we would not be able to fulfill our mission of teaching the nation's doctors. So clearly, that is not a viable solution if everybody came into a teaching hospital with that request. But in isolated settings, it is okay to say, well, in this case then, all right, we will operate on you. The resident will be watching, they'll be in the room, they'll be observing, but they will not have a hands-on role in your care. And so there's no right or wrong way to go about it, but the patient has to have their rights respected, and if those rights don't jive with the commitment of a teaching institution, well, that patient can go elsewhere, but they have to know the role of that resident, whatever that role is. So in another case, we have a 44-year-old Korean hedge fund manager. She is looking for treatment for her tired-looking eyes. She doesn't have a lid crease. Her mother has a very similar appearance. In fact, her corneas are almost nearly hidden by the excessive skin. Her mother's never had surgery. So she gets a recommendation of a coworker, and she sees a very prominent local plastic surgeon. He's got celebrity glossy photos in his office. He's got the Best Doctor magazine covers on the walls with the cherry wood and the mood lighting. He's nice. He is very thorough with her with his examination and his discussion of the potential risks and benefits and alternatives to her surgery, which in this case is blepharoplasty. He takes all the time she needs to answer her questions, and she leaves having signed up for surgery very confident in her choice of a surgeon. Surgery goes uneventfully. He makes his standard lid crease incision and uses lid crease reformation sutures, which is very customary with many blepharoplasty surgeons. At her first weekly post-op visit, she's a little swollen and bruised. She's got a little foreign body sensation, but otherwise she's okay. She comes in at 2 weeks for her 2-week visit. Again, the swelling and the bruising are improved. The front desk staff, upon seeing her, are effusive in their compliments about her new appearance. She's escorted into the clinic room where the surgeon comes in. He's also very happy with the results and announces to her, now you have a great place to put your eyeshadow. Well, at this point, the patient breaks down, and she tells the surgeon through her tears, I don't care about eyeshadow. I wanted to get rid of my tired-looking eyes, not my Korean-looking eyes. So what went wrong here? This surgeon did flawless surgery. Everything went as the surgery was supposed to go. It was within standard of care as a surgical technique. So what was different here, however, was this patient had spent her entire life with a typical Asian eyelid with no lid crease. Any lid procedure in a patient is going to necessitate the formation of an incisional line. In most cases, we put that line in a patient's natural crease. When they don't have a natural crease, that incision is going to create one. In many patients, particularly who want to preserve their cultural identity, they're not going to want a lid crease that's very different in appearance from the lid before. And so Asian patients in this particular case, they need to know ahead of time not only the risks of bleeding and infection and need for further surgery, etc., the normal standard or informed consent, but a situation like this, they have to understand the nuances of the incision that has to be made for surgery and how it may change their lid appearance and may affect their feelings of cultural identity. So in this situation, the surgeon failed to address the impact of his typically high lid crease incision on a patient who didn't have a lid crease before. And that's where the surgeon failed in this situation. Speaking of blemishes, again, as surgeons, we have to be careful about transferring our impressions of what's an ideal result onto a patient. And some of you may be familiar with Cindy Crawford. She was a very famous model who modeled a lot back in the 80s. And when she first got her start, her first agent told her she had a mole just above the corner, the left side of her mouth. And they said, you know what, Cindy, you have a great future in modeling, but you know what, you gotta get rid of that mole. To her credit, she felt that mole was part of her. She didn't view it as a blemish or anything that detracted from her appearance, and she resisted that advice. Now it's her signature mark, and in fact, you can go online and find out how to get your own Cindy Crawford mole. So to summarize, again, if we are looking at basic informed consent and we created a checklist, these would be the features on your basic checklist. Have we talked to the patient about the nature of the procedure in advance? Have we detailed the risks, the potential upsides, as well as the alternatives, including not doing anything? Did we give them time to ask questions? Did we make sure that we were the ones who had this conversation with the patient and not one of our allied health professionals in our team? Did we make sure the form was signed, and did we give a copy to the patient? For higher level or extra credit, did we make note of any cognitive impairments or impairments in mental status? Did we allow for special considerations in cases of sensory or literacy impairment? Did we provide translators if necessary? Did we provide an opportunity for the patient to tell us in their own words what they understood from what we've told them? If there were others in the room, family members, caregivers, did we document that that person was there? Did we talk about the aftercare? Did we discuss that with them? Did we make sure we involved any role of any assistants or residents or other people in the operating room? Did we disclose our inexperience, if applicable, to the procedure at hand? And did we disclose any FDA status information to the patient about the treatment that they were getting? And if you've satisfied all these, then you get an A+ for informed consent process. I want to share with you, as we wrap up here, a patient from early on in my career who was one of the most unhappy patients that I've ever had in my practice. And she had ptosis, as you can see here on slide left. I did what I thought was a very good ptosis procedure. I had good symmetry afterwards. Her lid was lifted. She could see better now, but she was very unhappy with me. And she was unhappy because I hadn't prepared her for the natural effect of successful ptosis surgery in getting rid of that place where most women will put their eyeshadow. We call it a platform. Successful ptosis surgery gets rid of that because the skin bunches up above. All she needs at this point is a blepharoplasty, but I hadn't told her that ahead of time. And when she wasn't prepared for that, she was very unhappy with me. And so the take-home message from that is that nobody, including our patients, likes surprises. So when we talk about risk management, as we've been talking about during this course, I think sometimes people can have a resigned feeling like we don't have any method of really protecting ourselves. And it is true. We cannot prevent a lawsuit. In many cases, when things don't turn out like patients had wanted them to, many times they see that as an opportunity to gamble a little bit. Let's roll the dice. Let's see if we can get something out of this situation that didn't turn out like I had liked it to. So unfortunately, there's nothing we can do to prevent this from happening. But what we can do is make any case more defensible. And informed consent gives us an opportunity to remind a patient that nothing is guaranteed and nothing is certain. It respects their autonomy by making them active partners in the medical decision-making process. And it acknowledges this uncertainty. We assure them that we're going to do everything we can for the best outcome possible, but we can't guarantee it. And all the while that we're having this conversation with the patient, we are strengthening, hopefully, that patient-physician bond. And ultimately, that relationship is probably the most powerful weapon we have for the best patient care, protecting them as well as protecting ourselves.